Okay, here we go. Um, I'm checking my own waves, my sound waves. Yes. Um, Hi everyone. I am Anzu. Uh, Let me see. And I live in Belgium, which is a country somewhere in Europe. I have had psychosis 2 times, so that's from my disability part. And I'm on Second Life already for 19 years, and I mainly use it for social contact. I'm also co-hosting a weekly art show, show and tell at the mental health group in Second Life. In real life, I have two main hobbies among a lot of other ones: playing the hurdy-gurdy and learning Japanese. I have the honor to introduce the next speaker to you, and that's Dr. Jillian Miller. She is a developmental neuroscientist in the Department of Anesthesiology, Perioperative and Pain Medicine at the University of Calgary, Canada. She leads the pediatric anesthesia, imaging and neurodevelopmental science, also known as PAINS lab at the Alberta Children's Hospital. Her talk is titled Pain and Mental Health During and After Pregnancy and its Associations with Child Brain and Behavioral Development. Please welcome Dr. Miller to the stage.
Hello, everyone. Thank you for the opportunity to speak with you today. As a lifelong lover of simulation games and as someone with often awful stage fright, I was beyond excited to have my worlds collide today and to be able to share my research with you here in Second Life. This is an incredible format for a conference, and this might be the most original talk I get to give throughout my scientific career. So thank you so much. As many of you are meeting me for the very first time, I thought I would take a moment to share a little bit about myself with you. I hail from Calgary, Alberta, Canada, known as Cowtown. It's a beautiful city, picture framed by the Bow River and Rocky Mountains. It is here that I lead the Pediatric Anesthesia, Imaging, and Neurodevelopmental Science Lab, aka the PAINS Lab, and I'm also the National Co-Chair for Pain and Child Health, which is a global initiative focused on training the next generation of pediatric pain scientists. When I'm not busy conducting science, I'm busy playing with my 3 golden retrievers. I'm an avid dog sport competitor, primarily in agility, and also a hobby golden breeder. Therefore, my interests in pregnancy and development also seep into my hobbies as well. So first and foremost, I am a pain researcher, and so I thought I would start us off with a definition of pain. Pain is described by the International Association for the Study of Pain as a subjective, unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. Thus, pain can exist outside of tissue damage. It can be physical or emotional, and both of these things at the same time. The primary focus of my research is on chronic pain. Chronic pain is defined as pain persisting for greater than 3 months in duration. There are 2 types of chronic pain. In 2019, the International Classification of Diseases came out with a definition to help discern chronic pain as either a disease or a symptom of a disease. Thus, chronic primary pain, which is pain without a clear underlying condition or pain that appears to be out of proportion to any observable injury or disease. And then there's secondary chronic pain, which is linked to an underlying condition such as pain from cancer, surgery, or arthritis. Regardless of whether an individual has chronic primary pain or chronic secondary pain, chronic pain interferes with every aspect of daily living, including social, emotional, cognitive, behavioral, work, and school functioning. So it is important to note that chronic pain is a growing epidemic. 1 in 4 Canadians aged 15 years or older are estimated to be affected by chronic pain at some point across their lifespan. These numbers are similarly reported worldwide. If left unmanaged, it can lead to significant pain-related disability and extensive healthcare utilization. Globally, chronic pain is the leading cause of years lived with disability. The direct and indirect costs of chronic pain in Canada due to loss of productivity and increased healthcare utilization were estimated to be 40 billion Canadian dollars in 2019 alone. However, when I asked patients being seen through our intensive pain rehabilitation program what caused their pain, the large majority of patients could not identify an inciting event or cause for their pain. Therefore, a central initiative of my program of research has been to identify the mechanisms or factors underlying the development of chronic pain. The earlier in which we are able to intervene and prevent the transition from acute to chronic pain, the more likely we are to be able to prevent lifelong suffering in individuals. So just after finishing my PhD back in 2016, together with 2 of my other colleagues, we put together a model summarizing the literature, which has attributed a number of factors to the development and maintenance of chronic pain. Some of these factors include family influences, genetic influences, hormonal, inflammatory, and brain changes, as well as mental health status. However, there remained a big question about the timing of exposures because of many of these studies have been conducted in individuals who already have pain. Therefore, do the biological and psychological factors precede the development of chronic pain, or do biopsychosocial factors change following the onset of chronic pain and serve to maintain the condition? The answer is likely both, but I believe it's better to be on the side of prevention, intervention, as it comes to living with pain. I am of the mind that the risk for chronic pain actually precedes birth. However, the heritability of chronic pain is estimated to be between 38 to 50%. There's a large body of animal literature that has demonstrated that our body's ability to handle stress and respond to stress is actually primed in the womb. An example of this comes from studies looking at the licking and grooming behaviors of mother rats. The brain stage of a newborn rat is actually equivalent in development to a human fetus in the 3rd trimester. And same as humans, there are natural variations in the attentiveness of mothers. Some rats demonstrate high licking and grooming, while others demonstrate low licking and grooming of the rat pups. The licking and grooming of the pups actually stimulates the production of serotonin in the pup's brain. Serotonin is often called the body's natural mood booster. The serotonin then it connects to serotonin receptors, which then initiate a down signaling cascade that leads to the production of glucocorticoid receptors, also known as stress hormone receptors. Therefore, the more the mother rat licks and grooms her pups, the more these stress hormone receptors are created. These receptors then embed themselves in critical areas of the brain, like the hippocampus. And then when an individual experiences a stressful event and stress hormones are released, these stress hormones bind with these receptor cells in the hippocampus. And after a particular threshold is met, they will signal the body to stop producing stress hormone. Therefore, if fewer receptors are within the hippocampus, the stress hormones will continue to circulate through the brain and body for a longer period. And over time, these circulating stress hormones can contribute to a number of known health conditions, such as depression, addiction, obesity, and cognitive-related impairment. In some senses, this is adaptive. If the mother rat is not licking and grooming her pups, it might be because she herself is stressed. And therefore, by not licking and grooming her pup, she is priming her pup to be born in a more stressful environment. Therefore, that pup will be naturally more hypervigilant. This makes sense if the environment the pup is being born into is indeed stressful. They will need to be more resilient to handle that stress. But if it's not, then this hypercirculation of stress hormones becomes maladaptive. Similar studies have been conducted to show that prenatal stress, neonatal pain exposure, postnatal stress, maternal separation, and resource scarcity can all lead to the priming of future stress responses through similar mechanisms. So we really wanted to look at what are some of the long-term effects of early stress hormone priming. To do this, we partnered with Dr. Rochelle Machazik out of Monash University in Australia. In this study, we had two groups of rats. Some were reared with their mother as per normal, and the other group were separated from their mother 3 hours a day for the first 2 to 12 days of life before being weaned at day 23. Once they were adolescents at day 35, they were sleep deprived for 4 days using gentle handling for 5 hours a day during their normal sleep hours. And this is to reflect a common adolescent experience of sleep deprivation. Then at day 39, they underwent a hind paw incision surgery under anesthesia. So these graphs show the results of that study. The top two graphs are examining males on the left and then females on the right. And it's looking at their responses to light touch from baseline, post-sleep deprivation, pre-surgery, 1 day post-surgery, and 3 days post-surgery. At baseline, both male and female rats that were exposed to maternal stress were less sensitive to light touch as compared to the non-stressed animals. Thus, they were primed early in life to better handle minor exposures to stress. However, when the stress compounds is when we see these animals fall apart, and thus following the sleep deprivation and onwards, for both the male and female rats exposed to maternal stress, they became more sensitized to light touch. The bottom two graphs on this slide demonstrate the results of time being spent in the open arms of an elevated maze. More time spent in the open arms reflects lower anxiety symptoms. The left graph shows the results of the male and female rats at baseline, and the right graph shows the results of male and female rats after sleep deprivation. At baseline, already the male and female rats spent less time in the open arms of the maze. However, this symptomology was much more exaggerated after the sleep deprivation, and therefore these animals exposed to early life stress had more anxiety-like symptoms. So what does this all mean? Again, the newborn rat is comparable to the third trimester of human brain development. We know from this literature that stress exposure during this period of time primes the central nervous system for how we respond to stressors throughout life. Prenatal or neonatal exposure to stress increases the risk to be more physically and emotionally sensitive to subsequent stressors experienced later in life. Therefore, this demonstrates a path for the intergenerational transmission of stress, meaning if you have a highly stressed and anxious parent, this is one way in which those behaviors could be passed on to you. And this might be similar for how pain risk is transferred from parent to child, but the intergenerational transmission of pain is an understudied area of science. So the rapid hormonal and physiological changes occurring during a normal pregnancy give rise to recurrent and sometimes constant pain for women. For example, the musculoskeletal changes as a result of gestational weight gain or postural changes to accommodate a growing fetus have been linked to causing pain. Overall, there's a broad presentation of pain during pregnancy with reports of pain in the truncal, lower body, and head and neck regions. However, pain during pregnancy has not been well characterized. Reports of pain prevalence vary widely in the literature, from 30 to 85% of mothers experiencing pain, depending on how, when, and what kind of pregnancy-related pain was measured. Additionally, pain during pregnancy is strongly associated with internalizing mental health conditions, such as anxiety, depression, and in addition to insomnia. Pregnancy is often regarded as a vulnerable period in an individual's life when increased pressures and worries related to pregnancy, labor, delivery, and the well-being of their child leads to increased anxiety and depressive symptoms. Previous studies indicate that anxiety symptomology is present for 16 to 43% of pregnant individuals, whereas 7 to 23% of pregnant individuals may develop prenatal depressive symptoms. The postpartum also represents an interesting period for evaluation of pain experience due to the continued changes in physiological processes. As part of labor and delivery, tissue damage at the site of the incision, as part of cesarean section, or the perineum from vaginal delivery have been associated with greater pain. Alterations to daily activities such as breastfeeding or the persistence of pain first experienced during pregnancy have also been implicated in postpartum pain reports. Postpartum pain after childbirth has been inconsistently described in literature due to varying definitions regarding the type, duration, and timing, and the report of pain. Previous reports suggest, again, that 15 to 80% of postpartum mothers experience some type of pain, with the assumption that pain resolves for most individuals beyond 1 year postpartum. However, a few studies examine pain throughout pregnancy and into the postpartum beyond 1 year. The majority of focus when evaluating pain in this population has been restricted to cesarean scar pain, vaginal pain, and perineal pain. Unresolved acute pain in the early postpartum thus increases the risk for the development of chronic pain in the following months after childbirth. Persistent pain in the postpartum has been associated with profound interference on quality of life, and this may impact a mother's ability to engage in self-care activities, such as hygiene and their physical functioning, also could interfere with their sleep and cognition, and it may hinder work-related performance, as well as the care of their infant. Prenatal anxiety and depression are also considered strong predictors of postpartum mental health conditions. And psychosocial factors, including maternal support, maternal self-efficacy, or self-belief and confidence, and that the mother has the ability to care for her infant, are all strongly associated with better maternal health. Postpartum anxiety has been shown to be present in 8 to 17% of mothers, and postpartum depression is present in 17 to 19% of mothers. Mood disturbances in the postpartum can greatly impact maternal functioning. Postpartum depression and anxiety are significantly associated with poor household, personal, and social dysfunctioning. Disruption in maternal-child interactions have also been associated with anxiety and depression. And mothers with mood disorders have been found to report more unsettled infant behaviors, having more challenges with breastfeeding and worse maternal bonding. Now, some work has indicated that there may be relationships between postpartum pain, anxiety, and depression, but more research is needed on these topics. We know that comorbid mental health conditions can, however, serve to maintain chronic pain conditions. It is known that children of parents with chronic pain are at risk for poorer physical health and worse psychological and functional outcomes, and that the heritability of chronic pain is between 38 to 50%. The intergenerational transmission of pain risk from parents to children has been described in a model with 5 proposed mechanisms associated with the relationship between parental chronic pain and pediatric chronic pain and adverse outcomes. These factors include genetics, alterations in neurobiological development, pain-specific social learning, general parenting and family health, and exposure to stressful environments. The component of this model that has been studied the least is alterations in the neurobiological development in children and mothers with chronic pain. Importantly, the connections within the brain, also known as the white matter, can be measured non-invasively. White matter undergoes constant remodeling across the lifespan, with modifications occurring during this processes of learning or activity across development and aging. Changes in white matter have been observed in pain populations and have been used to forecast pain persistence, as well as used to predict the transition from acute to chronic pain. Specifically, white matter changes have been found in tracts connecting areas of the brain involved in pain perceptions, such as tracts connecting the thalamus and brainstem and the sensory motor tracts. Despite what we know of white matter changes in pain and the ability of white matter to change across the lifespan, no studies to date have explored the association between maternal pain and child neurodevelopment of the white matter microstructure. This brings me to the primary aim of this talk, which is to investigate the trajectories of maternal pain, anxiety, and depression in the perinatal and postpartum periods, and possible associations with child white matter development at 2 years of age. This work was led by my former PhD student and current medical student, Dr. Jenna Jessa. So trajectory analyses allow us to evaluate populations over time and to identify specific groups of participants who may be at higher risk for a particular outcome. It also allows us to study patterns over time. To date, there are few studies examining trajectories of pain during pregnancy into the postpartum. And while trajectories of anxiety and depression have been explored in the pregnant and postpartum populations, the influence of pain on mental health trajectories is not well characterized. So in this study, we included 5,181 maternal participants from across Canada. And the maternal participants were included if they were greater than 17 years old, resided in Canada, and could read and write in English or French. Participants expecting multiples were also included in these analyses, and there were no additional exclusion criteria. The initial enrollment survey collected sociodemographic information, and we asked questions about pain across multiple time points. So our time point 1 was sent to participants 5 months after intake, and subsequent surveys collecting information on pain were completed by participants at 12 months postpartum and 24 months postpartum. Overall, this sample was quite homogeneous. The majority of participants were white and were highly educated. Close to 50% of participants were overweight or obese prior to pregnancy. However, it's important to note that the ethnicity, education, and BMI data were quite aligned with census data of the average Canadian population, with rates of ethnicity and education being slightly higher in this population than average, and the rates of being overweight and obese being slightly lower. At time point 1, we had 1,720 participants who were still pregnant and 1,703 who were no longer pregnant. The median gestational age at time point 1 was 33.7 weeks. And given this, we tested for differences in pain intensity between individuals who were still pregnant versus those who had delivered, and found no differences in the pain intensity at time 1, time 2, or time 3 observed between individuals who had already given birth versus the individuals who were still pregnant at time 1. Participants completed surveys that included measures of sociodemographic variables. So this included previous medical history, including a self-reported diagnosis of anxiety or depression prior to pregnancy, self-reported gestational anxiety, depression, hypertension, or preeclampsia during the pregnancy period were also reported. Self-reports of pain for approximately 3 months and subsequent pain intensity were also collected. And then baseline anxiety and depression symptomology from the PROMIS anxiety scale and the EPDS were also reported. So in terms of statistical analyses, we use the latent class mixed modeling, which is the modeling I had explained previously to visualize multiple distinct outcome trajectories within a single population. And alongside this, we used adaptive lasso to identify which variables were most critical to the model's predictability. For pain intensity, our best fit model here included a 3-group model. The weighting of our trajectory groups was 16% of individuals in trajectory 1, or our late postpartum group, which is shown here in red. This group demonstrated no pain during pregnancy and the early postpartum period, with pain beginning to present 1 year after birth and then having significant pain by year 2. 8% of the individuals were in trajectory 2, or our early pain postpartum group, which is shown in blue. This group had minimal pain during pregnancy and the early postpartum, with pain significantly increasing by 1 year postpartum and then resolving by year 2 postpartum. And then 77% of the sample was in trajectory 3, with no pain being observed or across the 3 time periods assessed. We found that mothers with a BMI classification of overweight or obese, a highest education level of high school or less, lower socioeconomic status, a self-reported pre-pregnancy diagnosis of anxiety or depression, gestational anxiety or depression during the current pregnancy, and report of chronic pain at baseline, as well as having higher baseline symptomology of anxiety as measured by the PROMIS scale or depression as measured by the EPDS scale, were all more likely to belong to the early postpartum pain group or the late postpartum pain group than the no pain group. Adaptive lasso revealed that lower SES, baseline chronic pain, and a pre-pregnancy self-reported anxiety diagnosis were the most significant predictors of belonging to the early postpartum pain group. Baseline depression symptomology, as measured by the EPDS total score, was the most significant predictor of belonging to the late postpartum pain trajectory group. In addition, the study participants who delivered full-term infants greater than 37 weeks gestation that were residing in the Calgary area were invited to have their children come back to participate in an MRI neuroimaging at 2 years of age. These children were without major birth complications or didn't have significant cognitive impairment, congenital anomalies, or contraindications to MRI. For this portion of the study, a total of 63 maternal child dyads were included in the analysis. And the average age at the time of the MRI was 29 months, and 39% of the participants were female. We used diffusion tensor imaging MRI to examine the white matter tracts or connections present in the brain. The main value that we took from these scans is fractional anisotropy. This gives us a value between 0 and 1 to indicate the directionality of water movement in the brain. Within the white matter tracts, we expect water diffusion to be highly directional, as cellular membranes, axonal packing, and myelination limit water movement perpendicular to the cells. Specifically, we collected diffusion data in 5 areas of interest based previously on other studies of white matter and pain. And these tracts included the thalamoparietal, thalamo-precentral, thalamo-postcentral, cingulum, and uncinate fasciculus tracts. Oh, I hope all the people, oh, look at the spelling. The translators are so good. In both the left and right hemispheres, we did this. All right, and then the relationship between maternal pain trajectories and child fractional anisotropy values were examined using linear regression models. So it is very important to interpret the following findings with caution, given that this is an exploratory sub-analysis with a very small sample size. But of the 5 white matter tracts we examined, we did find significant differences within the left cingulum, which is shown here. The cingulum connects the frontal, parietal, and temporal brain areas and is involved in sensory, emotional, and cognitive components of pain perception. Specifically, lower fractional anisotropy was found in the left cingulum of children with mothers that belonged to the late postpartum pain trajectory group and reported chronic pain at 2 years postpartum, which comprised 10% of our sample. And this was compared to the children with mothers that belonged to the no pain group. This means that a less mature pattern of white matter was present for children whose mothers reported a chronic pain problem at 2 years postpartum. Thus, this study was able to demonstrate that there are subgroups of pregnant individuals with different pain experiences throughout late pregnancy to the early postpartum up to 2 years postpartum. Higher reports of pain in the postpartum period are related to pre-pregnancy anxiety, pre-pregnancy depression, gestational anxiety, and gestational depression. And in a smaller sample, we found some evidence to suggest that there may be a relationship between maternal pain exposure and child white matter development. The parents and children from this study are still being followed over time. And so we, as in Dr. Jessa and I, are currently working on updating her analyses from her PhD. And we're now looking at the maternal pain trajectories from pregnancy up to 3 years postpartum as it relates to child brain development and socioemotional outcomes. Madison Torrey, pictured here, led this work as part of her undergraduate honors thesis, and she will soon be starting a physician assistant program at the University of Calgary. So therefore, in the same cohort as before, now including 5,720 mothers from across Canada, we had them report on whether they had been experiencing persistent or reoccurring pain over the last 3 months and their pain intensity at baseline, which was either during pregnancy or the early postpartum, and again at 1, 2, and 3 years postpartum. As this was the same sample as before, the demographics were largely similar to the previous study. On the left, you will find the original trajectory groups using the 3 time points found by Dr. Jessa, and on the right are the trajectory groups identified by Madison using the 4 time points. You'll find that these graphs are largely similar, except now that more pain was being reported at the initial time point across all 3 groups. But we still have a clear late onset pain group, early onset pain group, and a no trajectory pain group. When comparing the child-brain connections across the trajectory pain groups, we found significantly lower fractional anisotropy values within the genou of the pain groups as compared to the no pain groups. The genou is the anterior part of the primary tract that connects the left and right hemisphere of the brain. Its primary function is to enable interhemispheric communication, thus integrating higher-level cognitive functions like attention and working memory. Thus, exposure to maternal pain was associated with less left and right brain hemisphere communication. And this was also associated with more socio-emotional problems observed at 3 years of age. This now brings me back to the study I described earlier. Similarly, what we found in this study with the human mothers and infants, we found that early life stress exposure was associated with an increased risk for anxiety-like symptoms. But this begs the question, what happens now with subsequent stress exposures in this population or in another population? If you're already at risk from birth, what would a subsequent exposure like surgery do for changing your responses to pain? So we know from the literature that perioperative anxiety and pain catastrophizing. So pain catastrophizing is the tendency to ruminate, exacerbate, and feel helpless in the presence of pain. Both the anxiety and catastrophizing has been associated with greater pain after surgery. Moreover, greater pain after surgery is associated with an increased risk for chronic post-surgical pain, or CPSP. However, very little is known about the neurobiological risk factors underlying these relationships. This brings me to a study led by Lily Rubel, who recently completed this project for her undergraduate honors thesis and will be applying to clinical psychology programs in the upcoming year. She examined the relationships between perioperative anxiety, pain catastrophizing, and brain responses with pain outcomes following major surgery in adolescents. So for this study, we recruited youth between the ages of 10 to 18 years that were scheduled for major general thoracic, plastic, or orthopedic surgeries. 1 to 4 weeks prior to their surgery, they underwent a functional MRI scan and answered questionnaires regarding their demographics, state anxiety, pain catastrophizing, pain intensity, and pain interference, and pain interference is a measure of how pain interferes with daily life. They then underwent their surgery, and then 4 to 6 months following surgery, they repeated the functional MRI and the same questionnaires. When they were in the MRI, they were shown blocks of pictures of men and women expressing different emotions, such as fear or a neutral facial expression, as shown here. We then contrasted the brain's responses to fear versus the neutral stimuli and examined how these responses to stimuli changed from pre to post-surgery. So this study included 26 adolescents with an average age of approximately 15 years. 85% were female, as 77% of the population received spinal surgery to correct idiopathic scoliosis, and this is more common in females. 80% of the sample was white, which is somewhat reflective of the Calgary population. And 73% had already had chronic pain prior to surgery, as this was probably one of their main drivers for having surgery to begin with. We found that prior to surgery, individuals had a much higher functional response to the fearful faces as compared to the neutral faces. And this was specifically within the left parahippocampal gyrus. And this region plays a key role in connecting faces with memories. And this heightened response that we found pre-surgery then decreased post-surgery with decreasing pain interference. However, among the individuals whose brain activity remained heightened within the left parahippocampal gyrus from pre to post-surgery, they were more likely to report greater pain interference after surgery. Similarly, greater pain catastrophizing pre to post-surgery was also associated with greater pain interference after surgery. And this was over and above accounting for their age and state anxiety levels. This data would suggest that if we can pre-screen individuals ahead of their surgery, for ones who may be more environmentally sensitive and more concerned about their experience of pain, we could potentially offer additional supports for those individuals that may prevent either the transition from acute to chronic pain or prevent their continuation of pain from pre-surgery to post-surgery. And this may take the form, for example, of using cognitive reframing interventions such as cognitive behavioral therapy. And we are already offering some of these interventions at the Children's Hospital through our Bridging Pain service. And for those who go on to develop chronic pain, so are past the prevention, they're now at the intervention stage, they may also be seen by our intensive interdisciplinary treatment program. Okay, so I want to take a minute to talk about our intensive interdisciplinary pain treatment, or IIPT, at the Alberta Children's Hospital. This is a 3-week, 8-hour-a-day, weekday only, structured team-based rehabilitation program, which integrates physical, psychological, and medical care to restore function and reduce disability. The inclusion criteria for this program include that you must have been experiencing chronic pain for 3 months or longer, and that your pain still remains unresolved after trying 2 to 3 prior evidence-based treatment programs. The pain has to be causing major functional impairment in your daily life, and you are required in partaking in this program to be committed to an active self-management-based program. And the exclusion criteria is just any conditions that would limit their ability to participate in such a program. So previously we had conducted a study where we showed youth in the IIPT program the same set of emotional faces and an MRI scanner before and after IIPT and compared their brain responses. Similarly to what we found before, we found a reduction in hyperresponsiveness to emotional stimuli from pre to post treatment. And this reduction in hyper brain responsiveness was associated with a reduction in pain interference as well. Notably for this study, the primary activation change was within the middle frontal gyrus of the brain. The middle frontal gyrus contains the dorsolateral prefrontal cortex, or DLPFC, which is a common target site for repetitive transcranial magnetic stimulation. Repetitive transcranial magnetic stimulation is a non-invasive medical procedure that uses a magnetic coil placed against the scalp to apply focused magnetic pulses to stimulate the nerve cells in specific regions of the brain. It has been primarily used to treat psychiatric conditions like treatment-resistant depression and obsessive compulsive disorder, and it does this by rebalancing the neural activity. At the same time, I was finding this relationship with IIPT being associated with a change in activity within the DLPFC. I had attended a talk by Dr. Adam Curtin, whereby he was demonstrating how they use repetitive transcranial magnetic stimulation, or RTMS, to reduce depressive symptoms in pharmacologically treatment-resistant teens with depression. I thought to myself at the time, how great would it be if we could use their same protocol to target the same area of the brain to treat treatment-resistant chronic pain in adolescents? Or at the very least, we may be able to alleviate some of their depressive symptoms, and in that in and of itself may lead to a downstream effect of reducing some of their pain symptoms. Their protocol was 3 weeks in duration, and so it mapped perfectly onto the 3-week IIPT. Therefore, we targeted the left DLPFC for 60 minutes per day, 5 days a week for 3 weeks. We administered high-frequency stimulation, so 10 hertz for a 4-second long train. And the stimulation intensity started low to build up tolerance for the stimulation, and we increased it by about 1 to 2% every day until we reached their resting motor threshold. And overall, across the 3 weeks, this would have equated to 3,000 brain stimulations per session, or 45,000 brain stimulations over the course of IIPT. So this project was led by Si Chen, who is my incoming 4th-year undergraduate honors student, and she examined whether the addition of RTMS to IIPT was associated with reduced brain activity and lower pain interference after program completion. So whether or not we saw similar findings to what we had reported previously without the addition of RTMS, or better. So this study included 13 youth with chronic pain, aged 10 to 18 years. 9 had underwent RTMS and 4 did IIPT without RTMS. All completed the 3-week IIPT, and the ones that underwent RTMS received RTMS once every weekday. All of the youth underwent MRI scans and filled out questionnaires pre and post IIPT. The average age of participants in this study was 16. 67% were female, which is not surprising as chronic pain is more commonly reported in female adolescents. And then from pre to post IIPT, patients reported a significant reduction in their pain interference. Moreover, their neural hyperresponsiveness to emotional stimuli in the scanner significantly decreased across a number of brain regions. Once again, a reduction in brain activity over time was associated with lower pain interference, or vice versa. The ones whose brain activity in response to emotional stimuli remained higher over time had higher pain interference. However, interestingly, when we compared the pre and post pain interference outcomes from kids that received IIPT and RTMS to the ones who just received IIPT alone, we saw a much greater reduction in pain interference outcomes for the ones who received the combined treatment. So this really lended support for the addition of RTMS to IIPT for further improving the program's outcomes. Okay, so I covered a lot of studies. Let me tie this all together now. So we know that pediatric chronic pain is common and it's difficult to prevent and both to treat as well. The risks for pediatric chronic pain may even precede birth, and they can be exacerbated by life experiences such as surgery. Individuals may be at risk for developing chronic pain if they have an overstimulated central nervous system, leading them to be hyper-responsive to stimuli and potentially resistant to treatment. And so we are now starting to demonstrate that cognitive reappraisal and perhaps in combination with RTMS therapies may be effective in treating and preventing the chronification of pain. We have high hopes for the future that our work in trying to understand the development and maintenance of chronic pain will lead to earlier and more targeted and individualized treatments to prevent this challenging and often debilitating condition. And I just want to take a moment to thank so much to the organizers of this meeting for inviting me here today, choosing pain as your topic of focus. Thank you to everyone who attended my talk today or is listening online live or to the archive. I am so grateful to my collaborators, trainees, funders, and to the families who made this research possible. And I am happy to now take any Q&A.
Thank you, Doctor. There's a question from Mook. I may have understood this wrongly, but it seems like there was some challenge in distinguishing between intrauterine biological stress and postnatal environmental factors. Also, self-reporting of the psychological metrics is problematic.
Do I answer the questions, or does anyone lead the Q&A session?
Can you hear me?
I think I'm supposed to just go ahead. So there's a question here from Mook. It's multifactorial, so it might take me a few stages to answer this, but they say, it seems like there was some challenge in distinguishing between intrauterine biological stress and postnatal environmental factors. And I think that's absolutely true. Anytime you're conducting human research, it's very confounded. And so indeed, there's the possibility that there was stress both during and after pregnancy that had continued. And we can't really distinguish that entirely. What I will say is that in the first study I presented, we primarily found an association between the late onset pain group and altered brain development in the children. So it seemed to suggest that it was more the concurrent pain exposure or concurrent stress and pain exposure later on rather than during pregnancy that was the most impactful for the child brain development. But we have to tease this apart more. The main issue with this study that we found was that this was all secondary data analysis. This study was developed to look at pandemic-related stress during pregnancy and as it relates to child development. And we had asked the study leaders, led by Dr. Catherine Labella of the University of Calgary, to add on questionnaires about pain, but to limit participant burden, they were very limited in what we could ask about pain. So we were only able to ask if they had experienced chronic pain in the last 3 months, and if they had, what was their pain intensity. Based on these preliminary findings of finding associations between maternal pain and child outcomes, we now are writing up a grant to have this be a primary study objective, to study pain more thoroughly and really being able to disentangle stress during pregnancy and pain during pregnancy, and then from the postpartum period, and whether or not their pain during pregnancy is the same pain in the postpartum period, or if this is a new pain they're experiencing. We have a lot of questions that unfortunately we weren't able to get at in this secondary data analysis study, but I think the relationships are really novel and really add to the literature of what we found so far. You do have more to your question here, so I'll try to get to that as well. Self-reporting of the psychological metrics is problematic. I agree. It's not a perfect measure to have individuals report on self-report as our only measure of our psychological metrics. Ideally, we would have some observational or professional scaled measures as well. Again, that can be more intensive. So sometimes with participant self-report questionnaires, it decreases the level of burden on participants. What I find really important for our research is that their self-report measures are correlating with the objective biological measures. And to me, that gives some credence to their self-report, that we're able to tie it to a measure of which they don't have any control over. And I think that's pretty exciting and lending itself to our research. And it seems there is some risk of attrition bias. Yes, there is the potential of attrition bias risk. We usually do try to run analyses in our study to look if there are any contributing factors to who leaves our study. I believe we did that for the pregnancy and pandemic study and didn't find anything of note, but for some of the later studies that we've just had new analyses on, we haven't done those attrition bias risk analyses yet. So there is a possibility that some of the ones who did not complete, for example, our surgical study, had some reasons why they did not continue. Although the most common reason why they did not continue in that study is because the surgical study also happened during the COVID-19 pandemic, and that limited the number of just research-based types of questions we were allowed to have. We weren't allowed to bring people into the hospital to do MRIs just for research. They needed to have a clinical reason to be there during that time. So I think that was going to be the large reason for why we had attrition during a lot of these studies that happened during the COVID-19 pandemic, unfortunately. Okay, I hope I answered all your questions, Mook. I'll try to go to the next ones here, if there are.
I wanted to thank you for
I did not hear the Electra, sorry. I'm just kind of answering the questions as I find them here.
I don't think she can hear me.
So Katie says, did do a study? Oh, I think this is summarizing my reports. Thank you, Katie. Oh, here we go. A question from Gentle Heron. So some mothers chastise their usually teen children, saying things like, I was in labor for 33 hours. Maybe it's true that can affect behavior of the child and thereafter the relationship between mother and child. Yes, I think that's a great point. With another research colleague, we do a lot of research around our memories for pain and how that influences our future responses to our future experiences to pain and how we respond to pain, and then even how we model pain for our children, for example. And in that research, we found that individuals who tend to remember pain as worse than it was reported at the time, so we have a negative bias, tend to be at higher risk for chronic pain and tend to have more negative relationships with pain and pain behaviors, and an even future avoidance of other painful experiences like going to get vaccines and things like that. So I think there is a lot of negative repercussions that can happen from magnifying pain memories and talking about pain in a negative light, especially with children, and how that's modeled to their kids and how that could potentially influence their relationship with pain in the future. So a lot to unpack in that comment. But yes, I agree. I don't think it's a harmful way, a helpful way to talk about pain with your kids or teens. And it can re-emphasize pain-related fears and experiences that involve pain. I'm scrolling down. I just saw that Katie says 3 cheers for the epidural, just saying. And yes, Katie, absolutely. I think a lot of our work around pregnancy pain is promoting pain support for mothers. And this is in contrast with, some of the things that were coming out in the media earlier that some of you might have heard, where they were saying, pain's just like a natural part of maternal birth and we should just, suck it up. And I really think that's the strong point of this research, is to show that we shouldn't just be accepting pain, and that it's not a non-stressful event, and that this can have repercussions for the developing fetus and children and how they're able to support their children after birth and so forth. So yeah, I'm all for proper pain supports. Okay, I see another question from Mooks. Sorry to ask this, but did the pediatric anesthesia, imaging, and neurodevelopmental science pains come about by amazing serendipity, at least for this conference, or from careful intention? Ooh, this is such an easy, this is an easy question. I selected that name out of careful intention. I had an amazing supervisor during my undergraduate training. I've been looking at pediatric pain since my undergraduate degree. And she led what the acronym that was the OUCH lab. And so it was opportunities to understand child hurt lab. And I was so inspired by her to name her lab after a pain-related theme and have an acronym that just so summarized what her research was, that when I started at my own lab, I carefully considered for a long time about an acronym that could summarize my research and what I do. And yeah, it came together really thoughtfully. But yeah, I'm so happy that I could be here to speak on pain with all of you. And then, oops, sorry guys, I'm just trying to scroll through here. And then Orange Planer says, gentle, is that another form of I had to walk uphill in the snow in a 30-mile-per-hour wind to school both ways? That's good. Yeah, I think there's a lot of ways in which we can communicate and talk about pain. I have more concerns when it's like specifically related to health pain, just because I think it can lead to like future pain avoidance and fear of pain in health settings. But yeah, I think anytime, we communicate our agonies to our kids, we have to be careful in how we're doing that. And then Gentle responded, probably orange, but in the case of painful labor, it might actually be truly impacting the kid. And I agreed with that. Okay, I don't see any other questions coming through. We have 2 minutes left, but so if anyone has a last minute question, I'm happy to answer. Otherwise, I am leaving my email in the chat. If you're shy and you want to ask me a question privately, you're more than welcome to reach out to me by email, and I'm very happy to answer questions there as well, or send resources, or just have a chat. This has been such a great experience. I actually took a couple screenshots too, because I have been bragging about this conference to all of my colleagues and just thinking how amazing of an opportunity this was. And yeah, I'm so happy I could be here today.